taking a broader step today, beginning to look at a model of prevention. We know what happens to children who have been exposed to drugs, to alcohol, to any kind of substance during pregnancy. And we know that the outcomes are not good. So we can predict what's going to happen. And anything that we can predict, we can prevent. And that's what this webinar is all about, a model of prevention and early intervention to see what we can do for pregnant women and their children and their families to prevent and intervene as effectively as possible, looking at long-term outcomes. The reason that this takes so much discussion is that our research over the years has shown us that there are a number of barriers to identifying women and children affected by prenatal substance use. Those barriers fall into three categories: education and training, practice issues, and policy issues. Let's look at education and training first. When it comes down to it, healthcare providers, including physicians, are not really educated about addiction and even unsafe use of any kind of substance. There is very little in medical school curricula that address this issue. And when it comes down to it, especially when you address alcohol, there's a lack of basic knowledge of what alcohol's impact on pregnancy really is. And we can even expand that now as marijuana is becoming more and more popular and is becoming legalized in many states, that there's a lack of basic knowledge about marijuana's impact on pregnancy. Many physicians and other providers simply do not know how to screen women or how to screen children for risk. There's a lack of information about referral options, and I often get feedback from physicians who say that I'm not going to screen because there's no treatment available. So that underlying this problem is a belief that treatment of addictions really doesn't work. And finally, something that many of you have heard me talk about before, there is the NEMO syndrome, not in my office. There is still a significant bias as to the perception of who uses drugs and alcohol during pregnancy. From a practice perspective, there is a failure to utilize a validated screening instrument. Time and again, I hear from communities, from states that say, yes, we're screening for alcohol and drug use during pregnancy. We ask all women if they use drugs or alcohol. Many rely on the ACOG protocols that have very basic screening questions and ask the woman to check off if she's used drugs or alcohol during pregnancy. And we know that that kind of closed-ended question, did you use, simply doesn't work. Within offices and hospitals, there are a lack of protocols, and most decisions to screen will depend on an individual rather than any kind of protocol. There are time constraints, especially with managed care and its approach to return on investment, so that many practices are constrained in the time they have to apply themselves to addressing substance abuse issues. There's no real team concept. Many physicians say that's the nurse's responsibility to screen the woman. Many nurses say, no, that's the physician's responsibility. Also, one of the difficulties within systems is that there's very little follow-through on referrals. A physician's office may, in fact, make a referral to a treatment program, but feedback from the treatment program is very limited. And many people blame this on HIPAA regulations. And finally, there are payment issues. Although Medicaid does pay for screening and brief interventions, many states still have not approved the codes so that physicians and other providers cannot be paid for screening and brief intervention. And finally, the policy issues. When it comes down to it, substance use and abuse is marginalized. It's not taught in medical schools to any great extent. It is not really considered a medical problem by many, so that responsibilities then fall to the wayside. Something interesting that we have found just in the last few years of our research is that the placenta is a significant barrier to communication. We have found many instances in which the pediatrician is doing an MRI or an EEG to try to figure out why the baby, the newborn infant, is having seizures, when in fact the obstetrician knows that the mother was using heroin or opiates or other drugs during the pregnancy, and what the pediatrician is seeing are not seizures, but rather neonatal abstinence syndrome. And when we talk to physicians about this, we often get the reply, obstetricians can't talk to pediatricians because of HIPAA regulations. And that simply is not true. It has gone as far, in fact, when we talk with family practitioners, a family practitioner who delivers prenatal care to the pregnant woman and then is the healthcare provider for the infant, will not record in the infant's chart that the mother was using drugs, even though the provider is aware of this. He says he cannot put maternal information into the pediatric chart. Once again, that simply is not true. And it takes a lot of work, and in groups that we've worked with, it's taken involvement of the lawyers to help them understand that HIPAA should not be a barrier to communicating health information. There's also a failed connection between healthcare, substance abuse, early intervention, child welfare systems. The list could go on and on. Because when we look at this issue, we are looking at a long-term issue. We have a pregnant woman, but then we're going to be caring for that child at least through 18 years of age, and then certainly if the child has difficulties or deficits, those are going to affect his work behavior, his long-term success. So we're looking at a longitudinal issue here. And the connections, as the child and young person moves through life, the connections fail. And finally, as I mentioned before, there is a biased perception of risk. We published an article back in 1990 in the New England Journal of Medicine that showed that physicians select out African American impoverished women to do urine toxicologies on, rather than relying on medical indicators of risk of substance abuse, rather than talking with women and doing a screen. Physicians still rely on race and social class to tell them who is at risk for substance use. And I say physicians, but in fact, we find this across the board, from policymakers, nurses, other hospital staff, lawyers. There is this perception that there is a certain group of people who use drugs and alcohol, when in fact, all the research shows that the rates of substance use and abuse are the same across all social classes, all economic classes, all races and ethnicities. So this is a problem that reaches out across the nation. Now, why is this so important? Because we know from research, and this comes from a lot of the early work done by Anne Streisguth and her group in Seattle, Washington, we know that there are protective factors for substance-exposed infants. Being raised in a stable, nurturing home, no sexual or physical abuse, and then two key points: recognition of the problems related to prenatal substance exposure early, before the age of 6, and providing early intervention services. These last two factors are something we can control. And so we have to develop a system that recognizes risk early and ensures that all children prenatally exposed to any kind of substances receive the earliest possible intervention services. Now, for those of you that have worked with us in the past, you know that our overall framework is something we call the SART system. Now, the SART system was created long before the idea of SBIRT evolved, but in fact, they're very similar. In our system, the S stands for screening. And by screening, we do not mean toxicologies, but rather a universal approach to interviewing women that will identify the highest risk individuals across the population. So screening identifies risk. The second step, assess. Any individual, in this case any pregnant woman, who screens positive undergoes a further assessment to determine her strengths, her deficits, and her level of risk, and in this way to determine an appropriate treatment plan. And this is where brief interventions come into play. It's through the brief intervention process that you can understand quite a few of these issues as you talk with the woman. Referral ensures linkage to an appropriate type and level of treatment. And it's important to note here that there are various levels of treatment. Not all women, not all pregnant women need residential care. Many of the women that you'll find if you do universal screening will respond very well to a brief intervention and will not need any further intervention other than what is delivered through her primary care health provider. Treatment, we want to ensure that whatever treatment is available is of high quality and evidence-based. And the idea of evidence-based treatment is important because we know that women respond to treatment and engage in treatment in a way that's different than that for men. And so gender-specific treatment becomes a priority. So this brings us to our prevention system. What is response to intervention? Response to intervention strategies were first developed by the educational system, specifically to recognize and provide services to children in the school system who needed especially special education interventions. What I want to show you today is how we have taken this idea of response to intervention and adapted it to a public health model. We have utilized this model in several communities that we currently are working with, and it appears to be a very effective way of not only delivering services, but also communicating to the community what the purpose and structure of this whole process is. Now, what are our goals? For a public health system that is going to use RTI, response to intervention, that is going to use RTI as a modality for addressing substance abuse during pregnancy, we have 4 areas that express our goals. The first is prevention. We want to prevent the impact of prenatal substance exposure by early identification of all pregnant women at risk for substance use. And for the child, we want to prevent the development of the secondary characteristics that are associated with prenatal substance exposure by identifying the child as early as possible. And that gets back to what we talked about before with the necessity for identifying and providing services to the child before the age of 6 years. The second goal has to do with earliest intervention. Now, I know all of you have heard about early intervention, but we've begun using the term earliest intervention because there is an opportunity for intervention immediately in the healthcare setting, and specifically for the child. Once a physician or other provider identifies an individual who is at risk, an individual child who is at risk, that provider can provide intervention services immediately, often through family counseling and guidance. The third goal is early intervention. These are specialized interventions that will close skill gaps that can prevent future failure. And most people recognize early intervention as it's delivered through the early intervention programs that are available, as well as through the schools. So 0 to 3-year-olds usually receive early intervention through IDEA funded programs, and 3 to 5-year-olds receive early intervention through pre-kindergarten special education services. And finally, number 4, access to transdisciplinary treatment services for both the pregnant women and for the child. And we'll explain the term transdisciplinary, as we move along. Now, what are the basic tenets of RTI? In our use of RTI, it's a 4-tiered system. And what we're looking at is increasing levels of intensity of interventions as you move up through the system. And importantly, although there are 4 tiers, there's longitudinal tracking across all those tiers and the systems and services that are involved in each tier. A key is that as a child is in one tier, if he is found to be performing developmentally or behaviorally at a level that is below that of his or her peers, that child then moves up to the next tier. Another way to look at it is if the child fails to close the gap developmentally or behaviorally, in spite of the well-implemented interventions at each tier. And finally, a basic tenet of RTI is that we are going to use evidence-based strategies. So let's look at each of these tiers now. Tier 1 is universal screening and earliest intervention. Now, what do we mean by that? We want universal screening of all pregnant women and universal screening of all children within the primary healthcare setting. Now, you actually can implement screening beyond healthcare. And something we ask many of our communities is, where are the narrow gates in your community where pregnant women gather and where children gather? And so that means that we can implement universal screening in childcare centers, in church nurseries, in preschools. So there are all sorts of places that universal screening can be implemented for children. Screening for pregnant women can occur not only in the prenatal care site, but also through WIC, through other social welfare programs, domestic violence shelters. So you have to think broadly beyond just the healthcare system, because we want to reach out and find women and children at risk. Now, there are a variety of ways to accomplish this. As I said, it's grounded in universal public and professional education. So the first step in implementing Tier 1 is that we need to educate the public and professionals. Part of the goal of this education is to remove the stigma that's often associated with substance abuse and with mental health difficulties. All children in a school system or in a provider's office receive Tier 1 interventions with universal screening. And again, if a child, let's say in a provider's office, screens positive, then the provider can guide the parents on how to address the child's deficits. And this is why I personally like the Ages and Stages questionnaire, the Ages and Stages questionnaire social emotional. Many of you know it as the ASQ. The ASQ not only provides a validated, well-researched screening strategy, but at the back of the manual of the ASQ information, at the back of the manual, there are interventions that parents can apply for all the different kinds of difficulties the child may be having. And so the provider merely needs to turn to the back of the manual and talk with the parents about some of the things they can do to help the child. Tier 1 screening and earliest intervention, as I just described it, can occur at all the narrow gates in the community where children gather. Now, what do we expect at Tier 1? What you'll find is that about 80% of the children you screen will not require any further movement through the tiers. Your earliest intervention that you provide to the parents to help the child will be all that that child needs. The way we implement Tier 1 and the assessment through Tier 1 is with universal screening, as we've mentioned, using an evidence-based instrument. I happen to mention the ASQ, ASQ-SE. There are other instruments that are available that you can look at to decide what would be best for your community. The intervention at Tier 1 is through family counseling and guidance. It's what I call earliest intervention. And then who's responsible for this? The primary health care provider, the child care provider, any other community providers that have direct access to children. Those children who have a positive screen, and we're estimating from our work about 20% will have a positive screen, they will need to be moved up into early intervention services. And about half the children that you move up into early intervention Tier 2 services, Tier 2 will be adequate for them. So who receives Tier 2 services? Any children identified as at risk via a positive screen and for whom Tier 1 interventions were not supportive enough, those children need to move into Tier 2. Now, Tier 2 interventions include family support and guidance, but also IDEA services, Part C for children 0 to 3 and Part B for children 3 to 5. All states are required to provide IDEA services to any children in need. The Part C services most often are home-based. Providers will come to the home to assess the child and see if he or she does qualify for early intervention services. Part B, as I've mentioned, is delivered through the school system. Our expectation is that 20% of children will be at risk and will succeed with, and about half of them, 10%, will succeed with the targeted interventions that are delivered through Tier 2. So you're going to take care of another 10% of children through Tier 2. The assessments are evidence-based across the developmental domains, and this is when we get into occupational therapists, physical therapists, speech and language specialists that are doing the Tier 2 evaluation. Interventions are evidence-based across the specific practice or specialty domains. And the roles and responsibilities, as we've mentioned, Part B of IDEA for 3 to 5-year-olds and Part C for 0 to 3-year-olds. Now, what you'll notice at this point is that we haven't really talked about any kind of extra money that's needed. These services, everything we've talked about so far, are already paid for through various streams of funding. Now, we said that 20% of children would be referred into Tier 2, and about half of those children, that's all they would need. But that leaves us another 10% who are going to need more focused therapy and who will move into that, those 10% of children will move into Tier 3. Tier 3 children are those that do not make adequate progress through Tier 2, or in some cases, the family simply cannot support the developmental needs of the child. And the family is going to require more specific intervention. The interventions are grounded in targeted assessments and specifically addressing areas of deficit. And this can take place through group interventions, through parenting education and support, and through intensive school based interventions. Now, notice we're not talking about overall comprehensive evaluation for this population of children, but rather very specific targeted assessments that address the areas of deficit that have been uncovered through screening and through the Tier 2 interventions. Not all children need the highest level of assessment and treatment. And so this is a way to use resources more effectively. Who delivers this? It's the specialized clinical programs in the community. For instance, if you have a program that specializes in attachment disorders, or there's a program specifically for children with autism, those are and then as well as the schools can provide Tier 3 interventions. The expectation is that 10% of your overall population of children moved up into Tier 3. And what we have found is that 6 to 8% of the children in your overall population will respond well to the focused interventions that occur in Tier 3. Assessments are very focused on specific areas of deficits and concerns. The interventions are evidence-based, unique to the various fields of specialty, and the roles and responsibilities, these fall to community-based behavioral and mental health providers. When I talk about a focused assessment and intervention, I want to use this to illustrate what I mean a little bit further. In Tier 3, the child comes with a specific issue. Let's say a significant speech and language delay. So you focus, you ask, what is the problem? Through your assessment, you figure out the source of the problem. Is it a hearing loss? Is it a problem of muscle tone? So the child has delayed speech. There are a variety of issues. So through the assessment, you find out why the speech and language delay is there. And also through assessment, you figure out what can we do about it. And then, of course, the good clinician will track the child, and as you provide the interventions, ask, is it working? And so it's a very simplistic kind of approach, looking at specific problems of the child. Through this process, however, if it's found that the child is much more complex and is not responding or able to respond to a Tier 3 intervention, that's when you move to Tier 4. Tier 4 is comprised of comprehensive assessments and treatments. And from our estimates, about 2 to 4% of children in a community will need this level of assessment and treatment. This by far is the most expensive level of intervention, but again, you're saving it for those children who really need it. So the children who make it to Tier 4 are the children who have essentially failed through the other 3 tiers, mainly because their needs are so complex or that the family environment is not functioning in a way that enables the child to make progress. Tier 4 interventions are grounded in a comprehensive transdisciplinary assessment across all domains of child and family functioning. So this is going to result in a comprehensive treatment plan that can guide interventions across multiple domains. So this is the very complex child. The comprehensive assessment is conducted and the treatment plans are developed within a highly trained transdisciplinary children's mental health center. And we have worked with many communities across the nation to develop these transdisciplinary mental health centers. The assessment certainly is done there. Most often, therapy also is provided through the center, or in some cases, you have community-based providers who have very specialized, high-quality expertise that can provide the treatment. This is important when you get to geographic concerns. You need to make sure that whatever high level of treatment is there, it's available and easily accessible for the family. So the expectation is that within your community, 2 to 4% of the children or students may require this highest level and most expensive level of intervention. The assessment, as I said, is through a transdisciplinary team. So I want to talk a little bit about transdisciplinary. Many groups come to us and say, oh, we have a team made up of all sorts of different disciplines, and the child and family go around and they get their evaluation from all these experts in their various disciplines. That is not a transdisciplinary approach. That is a multidisciplinary approach. And there is a big difference. In a multidisciplinary approach, this is classically a very medical-based model. The psychologist, the social worker, child welfare, OT, PT, speech and language, whoever else is caring for the child, will each do his or her evaluation of the child and family, and then send in a report, and that report most often goes to the physician. Because when it comes down to it, it is the physician who is in control of what services will be offered and what services will get paid for. And so you have a very physician-controlled scenario. On the other hand, the transdisciplinary approach takes those same professionals and puts them in the circle with the physician out in the circle with the rest of the professionals. So the other professionals, including the physician, are sitting out in the circle, and the family is at the center of the circle. And what's different about transdisciplinary is that all of the professionals are required to communicate with one another with the family present and very involved in the conversation. And so it is a completely different approach to assessment and long-term management. Now, there are some basic requirements for a transdisciplinary assessment and treatment approach to be successful. All professionals are knowledgeable as to the work of all other professionals. And I hate to admit it, but I was shocked at the number of physicians who didn't really understand what, for example, an occupational therapist does. And so in building a transdisciplinary team, you have to make sure that all the professionals on your team are knowledgeable about the work of all other professionals. Secondly, and this is vital, all the professionals on the team must respect the work of all the other professionals. We had an instance with the team that we were working with. We built the transdisciplinary team. We built a very a beautiful center. Everything was ready to go. And literally the week before the program was to open, the pediatrician sat back, folded his arms, and said, "I don't believe in OT," and said he would not write prescriptions for occupational therapy services. Well, of course, we immediately had to remove that physician from the team and find another one. But that's a practical kind of difficulty you're going to come up against. The third, and this is where there is some reluctance at first, but in developing a transdisciplinary team, all the involved professionals create and sign off on one consolidated assessment report and treatment plan. Now, in some situations, we've had the schools reluctant to do this. Their concern being that if there is something that, for example, the occupational therapist on the team recommends, and the school signs off on that, that means the school is going to be responsible for that school-age child's services. Well, yes, that is correct. But that's again another issue that has to be addressed as you build this transdisciplinary team. When it comes down to it, however, the research has shown when you randomize children into transdisciplinary versus multidisciplinary assessment and treatment, children who are assessed and managed through transdisciplinary teams fare much better. In our own work, we found that children in the foster care system, if randomized into the transdisciplinary system, stayed in foster care a shorter period of time, moved to permanency placement more rapidly, and had higher developmental scores after 3 years. So there's quite a bit of work that's been done on transdisciplinary versus multidisciplinary assessment and treatment, and I highly recommend that you look further into this. In Tier 4, we expect that 2 to 4% of students our children will require this. The assessment is through a transdisciplinary approach. The interventions are evidence-based and adapted to serve the transdisciplinary modality. Roles and responsibilities. The transdisciplinary team is usually a community-based, highly specialized children's behavioral health team located at a center that can serve the community. Now, one of the issues we get into in working with counties or states with wide geographic distributions is that we will have our transdisciplinary center located somewhere in the community, and families are given transportation support to come in for their assessment. But then when it's time for treatment, we have trained treatment providers to provide the treatment services out in the community, or in other cases, we have a mobile team who travels across the community or state to provide the specialized treatment. So again, this is something that your community or state would need to decide in how to best address that. So what are some important steps you need to take as you consider implementing a public health RTI? First and foremost, you have to ensure that your community has a knowledge and capabilities to deliver a wide range of evidence-based assessment and intervention strategies. You need a structured format for communication and joint problem solving. And this includes a feedback loop between providers and systems with effective data sharing agreements. And we have worked with several teams to develop universal data sharing agreements that all their lawyers signed off on so that the school knows what's going on in the health care of the child, especially if the child's on medication, for example, and the provider is getting feedback from the school as to how the child is doing. The best way to accomplish this is through the medical home. Medical home is something that the American Academy of Family Practitioners, the American Academy of Pediatrics very much support and look to the primary care provider as being the individual to monitor the child's progress and to determine the effectiveness of the program long term. That does not mean that the medical provider, however, is in charge, but the medical provider is part of this transdisciplinary team and communicates with all other team members. And importantly, and this is a failure that we have seen in many communities, we have good training, strong training programs early on. People are delivering the evidence-based treatments, but then fidelity begins to lag. There is turnover. People essentially start moving away from the integrity of the intervention, so that we see that that there is a need to systemically and systematically continue to assess fidelity. In this way, you ensure quality control. The advantages of RTI, from our work, we have found that this universal approach brings in the entire community, and we've had a very positive response from the general community. There is early recognition of risk with timely earliest intervention, and the RTI gives you a way to address systems integration rather than service integration. We have many groups who talk about, well, they have all these disciplines involved, they have a multidisciplinary approach, they know who to call in the community if they need something, but that's just the point. If the social worker needs to find, for example, someone who can provide substance abuse treatment services to the mother, the social worker knows who to call. She has a friend who works in substance abuse treatment services, and she calls her. And that's how we're pulling and linking services together. We're integrating services. But the problem with that kind of approach is that once the social worker or the substance abuse treatment provider retire or no longer work within the community, you lose that link, and children and families fall through the cracks. Systems integration, on the other hand, creates protocols and guidelines for communicating across the system so that everyone knows how to communicate, what services are available, and how to ensure that families have full follow-through. The other advantage of RTI, if you have well-educated professionals with a variety of intervention strategies in their toolbox, then interventions can be individualized to best meet the needs of the child and family. And then a good RTI system supports best practice because you have ongoing assessment data that are collected and closely linked to intervention. So you not only collect data over the long term, but you actually analyze the data and use it to inform next steps for your system. I'll just give you one quick example. We worked with a community that developed an RTI system from birth through 18 years of age. Birth to 5-year-olds were all screened universally with the ASQ, ASQ-SE, and children starting at school age 6 to 18 years were screened with the pediatric symptom checklist. In fact, the school system at the beginning of the school year would send out the pediatric symptom checklist to all families before school started. It was part of the forms the families would fill out at the beginning of the school year. And so there was comprehensive screening of all children enrolled in school with the pediatric symptom checklist. At baseline, when we first started, we found that 18% of children were being screened across the community. 5 years later, that number was at 97%. 97% of children were being screened across the community. On the other hand, and importantly, we watched the rate of positive screens go steadily down, so that at baseline, 16% of children had a positive screen. 5 years later, 9%. So what we're seeing is that we're addressing risk across the community, and children with positive screens are getting the earliest intervention or early intervention or perhaps even tier 3 or tier 4 services, so that 5 years later those children's needs have been addressed and the rate of overall the rate of overall positive screens has gone down significantly. There are many approaches to addressing systems issues across communities. I think the work that all of us do is more complex than the work of most groups, in that all of you are probably working with substance abuse issues for pregnant women, but then also addressing the long-term needs and challenges of their children. So we're working across generations, across systems, and across a very wide range of providers. And that's why we have found the RTI system to be very helpful in this process. So I will thank you. I hope that this has been helpful. I encourage you to consider an RTI system for your community. If you have any questions or want to talk to me further about setting up these kinds of systems in your community, please do contact me. You can reach me through our website. I'll be happy to talk with you further. Thank you all so much for attending.